CMS is seeking comments on this and other sections of the proposed rule for next year. Of course, this is of major concern to the Academy and to other primary care societies and associations. They're asking for comment on the standards for coverage of the chronic care management services and on the certification of practices, whether that should be left to entities that certify for patient-centered medical home now, such as NCQA, or whether that should be broadened to include others, such as professional associations. The Academy is working with others on group comments and has also developed its own, and these include that the AMA and other associations oppose the approach of a patient-centered medical home certification to be able to render those services and to be paid for those services. That is opposition to that being the sole and exclusive approach only. We believe that other approaches to certification must be available for approval of practices to render the services. And again, so that would be that the standards are less expensive, less extensive, and that the certification approach is more timely than that would be available from current entities that are certifying. And standards and resulting payment must not miss the patient population, such as your population that is most in need of these services. And as we know, the patient-centered medical home approach is often applied and used in the office setting to patients that can get to the offices, and therefore, if the approach was not one that Academy members could apply and develop and become certified, then the goals of CMS would be missed in terms of providing services to this population, and certainly our desires to have those services paid and that care coordination and management that you and your staff provide would not be recognized and paid. And then payment must reflect the cost of the standards that are developed and your cost of rendering those services. Moving along the continuum and the emphasis on being paid for value in the future and to population management, and away from the traditional fee-for-service basis, is the implementation of a value-based payment modifier from the years 2015 to 17 in terms of implementation and then going forward. The ACA required the Secretary of Health and Human Services to apply a value-based payment modifier, first to specific physicians and group of physicians that the Secretary determines appropriate, and ultimately to all Medicare Part B physicians by January of 2017. The value-based payment modifier is to assess both quality of care furnished and the cost of providing that care under the Medicare professional fee schedule. Like other new services or bonus and penalty systems, the value-based payment modifier must be budget neutral, meaning that any upward payment adjustments for providers furnishing higher quality and lower cost care will be made based on the amount of downward adjustments applied to providers who furnish lower quality and higher cost care to Medicare beneficiaries. In some, it's a zero-sum game where the dollars that are available to pay for success with the value-based payment modifier will come from those dollars that are not paid out to those who have not met the criteria under the value-based payment modifier. In terms of implementation, 2015, the value-based payment modifier will apply to groups of 100 and more physicians based on 2013 data. So there is roughly a 2-year lag of the data that's being evaluated and the measures reported upon which the value-based payment modifier will be evaluated. In 2016, groups of 10 and above will then be included based on 2014 data. And in 2017, individual eligible professionals the value-based payment modifier will then apply to all physicians based on 2015 data. And then in conversations and in regulation, afterwards, other providers, including nurse practitioners and PAs, as the Secretary determines, could also be subject to the requirements and the bonus or the penalties of the value-based payment modifier. So what is the value-based payment modifier comprised of? There are various domains of both quality and cost, and there'll be various measures that you'd be reporting on that are under each of these domains. And the domains under the left for the quality composite, and value basically being an evaluation of quality over cost, clinical care, patient experience, population, community health, patient safety, care coordination, and efficiency, that being the quality of care composite, and then total per capita cost for beneficiaries with specific conditions, diagnostic codes that is. And then a new one proposed this year for inclusion is the Medicare spending per beneficiary, and that'll be the basis of the cost composite. A comparison of that would then create your value modifier score. So what happens? Those scores across specialties will be evaluated, and there'll be essentially a grid produced by CMS. Those to the highest on the upper left-hand quadrant or portion of this table here would receive the highest bonus payments, that they've achieved high quality under those domains and low cost under the cost composite, and that's the percentage on the Medicare portion of the allowed to which an adjustment would be made. What would occur under average cost, and if you were high quality and high cost, there'd be no change at all. Again, the dollars available for this would come from, as we move along the grid, to those that are high cost and average quality, or low quality and high cost. So again, the components from the slide before will feed into this calculation within CMS to produce, again, another system that is going to modify your payments on the Medicare fee schedule. Again, starting sooner for larger groups, and by 2017 for all physicians, and then with the potential that this would be opened up to other providers 27 to 15 forward. What are some other issues affecting outside of the fee schedule and the proposal for 2014? What are some other issues affecting home care medicine practice and payment now and forward? As some of you know, we've have talked about home health agencies and the proposed payment rule for 2014. We've submitted comments. We were concerned about a limitation of diagnostic codes, or diagnostic codes coming out of the payment system for home health agencies, and we were concerned that that would, again, harm the ability of home health agencies to take care of patients in the home, with your services, of course, as well, and have submitted. We appreciate and thank you for contributing your comments, and we have forwarded those on to CMS. DME, the face-to-face for designated supplies, was to occur this summer. That's been postponed to this fall. We're also aware that the bidding demonstration in various areas of the country is having an impact on access. Medicaid expansion was to include, and we'll go into more detail about this, the increase of Medicaid payments to the Medicare allowable amount effective this year, and it's unclear whether states have followed through and implemented that increase if a patient of yours was just a pure Medicaid beneficiary, for example. Medicare demonstrations are ongoing with the ACOs and independents at home. There's some indication that house calls are providing good value and explaining the success and cost reduction for ACOs. And of course, we are just at the end of the first year of independence at home, and evaluation is being conducted by CMS and its contractors. Again, we mentioned the ACA implementation. Insurance exchanges in various forms are being established across the country. There are basic benefit packages that have included the provision for services to patients that you would see, that they would have to be included in the plans that are offered in those exchanges. On an ongoing basis, there's fraud and abuse issues, additional HIPAA changes that are being implemented this fall, and we'll have a separate webinar on HIPAA coming up, and the implementation of the Sunshine Act. The next slide includes more specifics about the DME face-to-face and what were the covered items to be included, and that would be a specific listing of CMS, and that the face-to-face requirements would have been, in addition to that, this certificate of medical necessity could have been completed at the same time. There would have been, there is a new G code for the certification of a physician by the rendering of the face-to-face by a non-physician provider, and there was the coverage of the E&M, the face-to-face encounter. There was payment of that for that E&M code to the non-physician provider. Again, some additional details on this page, and then there's a specific carve-out here to the Power mobility devices that were have their own specific requirements outside of this, the face-to-face requirements. Next slide is a review of the Medicaid increase that was to occur this year, and it would be helpful to receive information from you whether you are seeing increases in payment in your states for services to Medicaid beneficiaries when they only have Medicaid coverage. Again, it was to increase to at least the Medicare rates in effect in prior calendar years, or if there was a higher rate in effect at 2000 using the 2009 Medicare conversion factor. Then primary care services were designated, and the primary care physician specialties to which this increase would apply. And the services that would have been covered are those that you're rendering in your house calls. States had some time to bring their changes and increase to Medicaid rates into effect, but then those increases were to be retroactive and lump sum payments paid to you. And again, we'd like to follow up with that information. Also, if you're receiving payments as a result through a Medicaid managed care organization or under capitation, those rates were to be increased on a commensurate basis. The next slide describes those primary care services that were to be included under this rate increase. And again, this was part of the Affordable Care Act. And you can see that this includes house call codes. So again, kind of wrapping up, where are we in terms of the framework for home care medicine? What is coming into focus, and the when has started, and as discussed with the complex chronic care management services, the value-based payment modifier, the ACO and independence at home types of shared savings approaches. Medicare payment policy is clearly moving. On the fee schedule basis, there's constraint moving from carrots to sticks, moving to value-based payment and population management. The potential that payment policy is going to attach to those that are certified as having met the standards and organized to deliver certain services. again, our encouragement for you to plan and to participate in this change, to evaluate where you are now in terms of being able to meet such standards, what you would have to do to get to a point to reach such standards. If that doesn't seem feasible, what sort of discussions that you can have with with peers and other organizations so that you can render those services and obtain that revenue. And also to participate on the advocacy on such issues affecting home care medicine practice, as we do on your behalf. And again, we'll be in touch with you in terms of these developments in your market. And again, if you're having experiences with certain payers or institutions, either asking if you are certified as a patient-centered medical home, for example, or saying that you'd be excluded from their networks, if not, et cetera. We want to get a tangible, on-the-ground understanding of what's occurring in your markets. Future Academy Practice Management webinars. The next webinar will be September 12th. That'll go over the requirements for compliance plans for practices, regardless of size, and we'll get into some service specifics, such as E&M services, the HHA and DME face-to-face encounters. Again, review the requirements for CPO, TCM, and go into detail about the proposed complex chronic care management services and the documentation for those services, and claim submission and payment. And unfortunately, the compliance area, through news reports this week, there's been more identification of practice with fraud and abuse issues that is in the public domain. And again, this highlights the need to have compliance plans in effect and to make sure that you're rendering services on a compliant basis. We will follow up with webinars on HIPAA and new provisions that go into effect and provide summary on the privacy, security, enforcement requirements. We want to develop a couple of standalone webinars on plan of care and care coordination and reporting, a basic level to the plan of care, and then also another webinar with considerations for the experienced practice. We're about a year away from the implementation of ICD-10, so webinar will be and resources will be provided. What is it and what should I do now, and prepare so that your services, so that you're rendering services and identifying them diagnostically under ICD-10 effective October of next year, and being paid for those services. There is indication that there will be no more delays of ICD-10, which was to have gone into effect this year. CMS has communicated that there is not going to be further delay, and so we want to help you prepare for that implementation, the resources and the changes to systems and processes and education, et cetera, that has to be put into place. We'll also develop webinars for nurse practitioners and physician assistants specific to independent practice, state-level requirements and organizational structure that relates to the specific states, and then specific practice considerations for nurse practitioners and physician assistants in independent practice. ICD-9 is still in effect and impacts HCC scoring and payment systems based on diagnostic coding and risk stratification. So we want to make sure that we provide you with information about diagnostic coding and HCC scoring and the relationship between the two. Contractual relationships are becoming increasingly important, and we want to provide resources both for use within your practice and growing your practice, relationships with health plans, ACOs, hospitals, home health agencies, and long-term care facilities, and also a primer on fraud and abuse relating to Stark and the anti-fraud and abuse provisions of the Social Security Act as an additional webinar beyond the one that's on compliance, that is at more of a service and documentational level. The fraud and abuse primer will be on a more structural level. Plan now to attend the May 4th, 14 and 15 annual meeting in Orlando of next year. We'll build on the success of this year's record-setting annual meeting in Dallas. There will be evidence of the value of house calls provided in the fee-for-service environment that's been identified and developed in ACOs and through IAH, in managed care in the VA. Join us to celebrate the history and legacy of Academy and house call field leaders. Celebrate the name change and expanded membership of the Academy. There'll be specific expert sessions conducted on a very interactive basis based on information in response to this year's annual meeting. Again, on a very interactive basis to respond to specific requests and enhance networking opportunities. And with that, let me thank you for joining this afternoon and leave the next few minutes available for questions. One question received was, in addition to the MSAs and the HPSAs, was anything mentioned for MUA P areas, medically underserved population? That term specifically was not identified in the proposed rule. I'll go back and double check and make sure that's also not something that's that might be. Well, I will confirm and see whether it is something that's out of the Office of Rural Health Policy, and provide that response. The Academy is transitioning to a new site for its website, and this webinar will be posted. It'll take after that transition to post the webinar from today. So again, look for this posting and response to any questions you submit as a result in the future, and we'll also provide those responses via the listserv or e-news as appropriate. And if there's leave a moment or two for any additional questions. And again, thank you for joining us this afternoon and providing your comments on the topics that have been sent to you during the past few weeks to help us provide comments on your behalf to CMS, and for that support, and for the support of the Academy, and remember the role that you play in advocacy as well. Thank you for joining us this afternoon, and please be sure to have yourself and any staff join us on September 12th for the important compliance webinar. Thank you, and good afternoon.